Welcome to As a Woman, Fertility, Hormones, and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today I am talking all about what I want you to know before doing fertility treatment. If you are considering doing treatment, even if you're in the middle of it, or if you're just trying to make that decision, this is the episode that is going to help and going to prepare you. The As a Woman podcast exists so that you can learn more about your body, fertility, health, and hormones. And today we are talking about that jump into treatment. I'm so honored to have you all here and all your love and support for the podcast. So thank you so much for all of it. I'm working on the next version of the podcast. So looking towards what the next chapter is going to be. And more than anything, I want to make sure the podcast is growing as we all are and as the audience is, and that the podcast still fills the need that you have. So please head over to Instagram at nataliecrawfordmd. You will find information so that you can submit your thoughts, what you love, what you hate, what you would like to see next as we take this podcast to the next version. You can find that over on Instagram, the link in my bio. Easy peasy little form that you can fill out. And just huge support for all of the questions, everything that you have called in. A lot of the episodes are based on the questions that you have and the questions you leave. So where do you send questions? You can send them on Instagram on Monday at nataliecrawfordmd. You also can send questions to the voicemail, and this is very easy. You can call 657-229-3672, and you can just leave your voicemail question, and this helps us decide what content we should cover, and you'll hear a lot of your voicemails included in some of the episodes. We also answer questions at the end of some episodes in our weekly Q&A series, and you will find some questions in the newsletter. So please go check out the weekly newsletter, nataliecrawfordmd.com/newsletter. You'll get access to some of the freebies we've created just by signing up, and you'll see fertility in the news, answers to some of your questions, my favorite recipes, every single week delivered right to your inbox. All right, we're going to jump in, and today we're going to talk about what you should know before fertility treatment.
Hi, Dr. Crawford. My name's Amanda. I am 26 years old. My husband and I have been wanting to get pregnant and trying to get pregnant for about 3 years actively. My question is, what is the process, or what should the process be when it comes to jumping right into IUI or IVF? I ask that because being young, I've done what seems to be all of the testing, meaning I've done the follicle count, the transvaginal ultrasound, I've done blood work, I've done ovulation testing, I haven't done any of the pills, I forget what it's called, but like the extra pills that can just help you ovulate and have a stronger, if you will, ovulation, but I just don't know what the next steps are, what the next step I should take is. I don't know if I should just jump straight into IUI or if I should just continue to wait and, try to do any sort of cleanses or whatever it might be in order to get my body, I guess, more prepared. I'm just trying to read in on what my body is trying to tell me. And I don't want to cause any symptoms to be worse. My period is pretty much regular. I do have pretty painful periods. They last about 2.5 days. I'm sure there's more information that you'd want to get in on, but I don't mean to make this voicemail longer than it already is. But anyway, I'd appreciate just some guidance on what I should do next. Thank you.
All right. Well, I'm so sorry for everything you've been going through, and I really appreciate you calling and asking a question because it sets the stage up for everything we want to talk about. The first thing to say is that this is a common scenario. You've been trying to get pregnant. You've been trying for a while. You finally go to the fertility doctor. You do testing, and it's normal. And then you're left with this, now what? And I think sometimes as physicians, people don't do a good job at explaining to you what this all really means and what your options are for the next steps. And I always try to break this down to my patients as in, here's what you could do next. And number one is nothing or the same thing. That's always an option for you. Now, let's back up one step. So the things I want to go through quickly are going to be number one, when should you do testing and what testing includes? Number two, what you should do with those results and should you do treatment? And number three, how you can prepare your body for treatment. And then we're going to answer a few more questions. So number one, fertility testing. Officially, if you've been trying to get pregnant for a year, and contrary to popular belief, trying to get pregnant does not mean I am tracking my cycles and I'm timing intercourse with when I'm ovulating. Trying to get pregnant means you are not preventing a pregnancy. You're not using birth control. You're not pulling out. You're not avoiding your fertile window with a tracking app. You're not using condoms. So if you are having unprotected intercourse, you are trying to get pregnant. You have your very highest odds of conceiving in the first 6 months that you're trying to get pregnant. So the vast majority of people will get pregnant in those first 6 months if they're going to get pregnant. And if you're under age 35, 70% of people get pregnant in the first 6 months. So once you're bypassing that, you are starting to get to the rate of diminishing returns. In the next 6 months, if you are young, you are going to see around 15% more people get pregnant, and that's going to be the most. When we go further, fewer and fewer people get pregnant, and that's because something's going on. Whether we can test for it or find it or not is always a huge question, but something is going on. So when should you do fertility testing? You can do it at any time. You can. I see patients all the time before they hit the magic infertility line in the sand who want to make sure everything's in working order. But if you are wanting to be more laid back and just want to test when it is indicated, if you are under age 35, that would be after 1 year, 12 months of unprotected sex. If you are older than age 35, that would be 6 months of unprotected intercourse. And if you're 40 or older, I recommend you get testing right away or 3 months max of trying. The reason for this change in recommendation as we get older is that it gets harder to get pregnant as you get older. You start to get closer to having fewer eggs remaining. But the bigger, more impactful factor as we age is that our egg quality starts to diminish. And when we talk about egg quality, what do we really mean? What we mean when we talk about egg quality is the chromosome normalcy inside your eggs. So when we talk about your eggs and your ovarian reserve, this is a part of your fertility testing. I can check your ovarian reserve, which is how many eggs do you have, and we can do this by an ultrasound and get something called an AFC, antral follicle count, or we can draw a blood test called AMH, anti-Mullerian hormone. This is telling us how many eggs are available in this month, and that is a representation of how many eggs are completely available. The analogy that I like to use or I like to think about, and if you've been here, you know what's coming. This is the vault inside the ovary. So I want you to imagine that inside your ovary is a vault where all your eggs are kept. Every single month you have a group of eggs coming out of the vault. And those eggs that are outside the vault are the only ones you get to work with that month. So normally one should ovulate, the rest will die, and the next month you have another group. When we do IVF or egg freezing, all we can do is get the eggs that are outside the vault to grow. That is our limitation. Now, what is fascinating is that the more eggs you have remaining in the vault, because we all know we're born with all the eggs where we're going to have, we run out of eggs over time, and as you have fewer eggs, you are going to have fewer eggs coming out of the vault every month. So an average 30-year-old should have around 20 eggs available each month. An average 40-year-old would have closer to 8. But everybody is on their own unique pathway. They're born with different numbers. We run out at different times. So understanding your ovarian reserve, how many eggs you have available, I like to think about it as a category, normal, above average, below average, critically low, is going to help us, number one, think and plan our reproductive future, decide how aggressive we might want to be with treatment, decide what our expectations or our success with treatment might be, and can be a representation of underlying causes. For example, a really high ovarian reserve can be found with PCOS. A really low ovarian reserve might be seen with endometriosis or autoimmune disease. So where you fall as compared to your normal can also be a clue, even though we will say a low or high AMH doesn't impact your ability to get pregnant as long as you're regularly ovulating. I think there's truth to that. If you have 10 eggs, 20 eggs, or 40 eggs, if you have regular periods and you're ovulating 1 egg per month, you have the same chance of getting pregnant. But my big asterisk is always, but why if it's not normal? But why? If it's high, is it PCOS, and does that have metabolic factors that are impacting? If it's low, well, what then? Is it endometriosis, or could you have celiac disease like me? Is there something causing that low reserve that might actually be impacting your fertility? And then when it comes to egg quality, we don't have a test for egg quality, and I know that's so frustrating. Your egg quality is the chromosome normalcy of your eggs. It decreases as you get older. You also can impact this decrease. Things like smoking cigarettes, being overweight, environmental toxins, high levels of inflammation, those things can all negatively impact your egg quality. And when we talk about lifestyle factors that can help improve your fertility, a lot of what we're talking about is trying to impact this chromosome stability inside both your eggs and your sperm. So we don't know about your egg quality unless we do IVF, and we can see how your eggs do in a lab. That gives us a lot of insight. But on the day-to-day basis, we just don't know. So we're going to assume your egg quality is equal to your age, which means at age 30, about 50 to 60% of your eggs are going to be genetically normal. Around age 35, we're going to be closer to 40 to 50%. Around age 37 to 39, we're going to have closer to about 30% or a third. At age 40, closer to 25%, 42, 10%. So you can see this starts to change really quite dramatically. So if you're coming in, understand that this change in egg quality, this change in ability to conceive as you get older is a big determining factor in our recommendation for when you should get testing done. But you can always get it done at any time. I have had patients come in for testing, and sometimes if you are young and you do testing before your quote infertility diagnosis and everything's normal, it can feel really reassuring. And you might say, great, we're going to keep trying naturally, but now I know I'm not running out of eggs. My partner has sperm, my anatomy is okay, and I can feel more confident in our attempts to get pregnant, less anxious or worried that something is going on. And if it was my perfect world, this is what we would do at a preconception evaluation. Let's test and make sure everything's right before you go spend a year trying to get pregnant. That's not the recommendation. I understand that's not the medical world we live in. But of course, I live on the other side where I see people who are struggling, and time is a variable you cannot control. So when you can control it, or you can take charge of time and not let time make that decision for you, that can be very impactful. So a full fertility evaluation is going to include tests of ovarian reserve, typically AMH and an antral follicle count, which is vaginal ultrasound. I do think it's important to note that a vaginal ultrasound gives us a lot of additional helpful information. So things like, are there ovarian cysts? Do we see endometriosis? How's your anatomy? How does the uterus look? And this is why if you have an ultrasound done and ordered at a radiology place, and now you're coming to me, I'm always going to redo it. And I'll tell you, I don't trust anybody, and I don't mean that meanly, but I want to be the one making these decisions and seeing your anatomy because it's so important. Next is going to be a complete evaluation of your anatomy, and this is going to include the inside of your uterus and the fallopian tubes. So I want you to do a little experiment, a little favor with me. I want you to hold out your palm, and then I want you to put something smaller than your palm in your hand. I have a lipstick. This is one of my favorite. This is Charlotte Tilbury, and it is red carpet pink, and this is my favorite everyday pink. Okay, so I've got red carpet pink inside my hand, in the palm of my hand, and if I put my second hand over it, like I'd be making a clap, you can't see the lipstick at all. You have no idea the lipstick is in here. This is what your uterus looks like on a vaginal ultrasound, meaning the uterus is a potential space. On vaginal ultrasound, it is collapsed and I can't see what's inside completely, so I can't see the lipstick. Now, sometimes it can be big enough, meaning if you go shove a pencil inside your hand, you might see it poking out. So there are some uterine abnormalities that you can see on vaginal ultrasound. If it's in the muscle part of the uterus, like a fibroid, you can definitely see it. But things that are inside the endometrial lining, you cannot always see. And those things can be highly impactful for implantation. Things like fibroids in the lining, endometrial polyps, scar tissue, uterine birth defects like septums. So in order to fully see these, you have to distend the cavity. So if I take my hands and I now open them up, open the steeple, right? Here's the church, here's the steeple. So now I open them up and I have two hands open. I can now easily see that the lipstick is in there. And that's a good representation of an endometrial polyp. So the way that we see inside the uterus is by putting liquid inside the uterus and then watching with some type of imaging. So this can either be hysteroscopy, where I put saline and a camera in the uterus. This can be a saline sonogram, where I put a little catheter to the cervix and then push saline in while I watch with vaginal ultrasound. Or it can be with an X-ray test, like an HSG, which is similar except it's radio-opaque dye, and then I'm going to be taking X-ray images. With two of these, the HSG and then with a saline, if you do a FemView or a bubble test, you can push liquid and see the tubes. The fallopian tubes you can't see on ultrasound unless they're highly abnormal or unless you try to distend them with liquid. So for an HSG, that radio-opaque dye moves through the tubes. On a FemView, you would see the bubbles of air moving through the water, and that could tell you the tubes are open. So you want to make sure that your fallopian tubes are open, inside of the uterus normal. That's considered the anatomical evaluation for a fertility workup. And then you're going to want a semen analysis. So a semen analysis is going to be an essential part if you have a male partner. This is going to tell you the count, motility, shape of the sperm. And then outside of this, just so that we're all on the same page, is some basic blood work that we recommend, including proof of immunity to rubella varicella, vitamin D, I like a thyroid, I like infectious disease labs, and genetic carrier screening in addition to your blood type. And then there might be more specific things. If you have luteal phase spotting, I'm going to add on a prolactin. If you have history of autoimmune disease in your family, I'm going to check for autoimmune thyroid disease. If you have PCOS, I'm going to check for hemoglobin A1C. So there might be more testing based on your clinical scenario. But blood work, ultrasound, other type of imaging, and a semen analysis is going to round out your fertility testing. All right, so you have the testing done. It comes back normal. Now what? This is the scenario we find ourselves in. Well, I think it's really important to know that in all age groups, your age of getting pregnant drops as you get older. We've already talked about that. So whereas your chance might be 20% per month at age 30, and it might be 12% per month at age 35, and it might be 5% per month at age 39, all of these numbers drop once you have hit a year of trying to get pregnant. So we'll use the 30-year-old had a 20% chance per month. Suddenly we are at a year of trying, and just statistically, even with all that normal testing, so you go through all normal testing, this gives you the diagnosis of unexplained infertility, which means none of the top causes, male, tubal, ovulatory, have been identified. Now you have a 4 to 5% chance per month, which is really a huge drop from 20%. This can be really frustrating. Two things are true at the same time. That's not zero. That's an ineffective way to get pregnant. But you could get pregnant. So I would always say, hey, all your testing is normal. Option number one, keep trying. It might happen, might take longer, might mean, depending on your age and how many kids you want, that time might play a role in you having your ideal family size. Once you've hit 2 years of trying with all normal testing, that number is now 2 to 3%. And once you've hit 3 years of trying, even if you're young and you've not gotten pregnant, it's now less than a 2% chance. And these are fecundability rates. These are monthly or cycle-based, chance per cycle. But if you now, the first line you said, we've been trying to get pregnant for 3 years, and now we have less than a 2% chance per month of getting pregnant, that is a very low number. Maybe it's next month, maybe it's in 6 years. And then what if you want more than one child? This is why it can be so frustrating. Now, top causes of unexplained infertility, you can have endometriosis or adenomyosis, inflammatory autoimmune conditions where your body essentially is very inflammatory, associated with painful periods. They're a little bit different. You can have other autoimmune disease, so undiagnosed autoimmune disease or inflammatory disease, just low egg or sperm quality, usually related to something that's not been diagnosed. Poor fertilization, so fertilization failure, and this could be due to sperm function, which is semen analysis does not check, egg quality, which we cannot check, or your environment. Remember that egg and sperm must meet in the fallopian tube. So to me, these causes are all vague, hard to diagnose, don't lead you to a clear option. And this is why when it comes to should you do treatment, in my opinion, if having a child is a life goal, you should, because it is going to improve your odds of getting pregnant. So what treatment exists in this scenario? And then we are going to go over what I recommend for fertility lifestyle changes, especially in the face of unexplained infertility. I wish I had numerous options for fertility treatment, but the truth is I have surgery, medications to make you ovulate, an IUI or an intrauterine insemination, taking the sperm and putting it further down the field, and I have IVF. And really that's what I've got in my toolkit. And that's not a ton of things. So if you are going through and we don't find anything to operate on, then that's off the list. If you already ovulate, that is something that I'm not going to be able to do different. When it comes to unexplained infertility, this is why doing ovulation induction alone or doing Clomid or Letrozole, medications to help you ovulate, does not change your odds of success. So the options we have for unexplained include, number one, combining treatments, improving odds. So ovulation induction with a goal of getting 2 or 3 eggs. So we call this controlled ovarian hyperstimulation, and an IUI or an intrauterine insemination. So if we imagine a soccer field, and I now have 2 goals at one end, and I take my players and I put them at the 50-yard line, I am improving the odds that we can make a goal. That's all we're doing here. If there is something that's blocking fertilization, for example, if there's a reason why the sperm functionality is going to prohibit fertilization, it's still not going to work. You're still not going to get pregnant because I'm not changing that. I'm not changing the environment. If it's hailing, it's still hailing during the game. I'm not making you make the goal. I am purely controlling timing and making sure that I'm putting enough eggs and enough sperm together to help it happen if it can. This is why with ovulation induction plus an IUI, your odds of success are going to be 8 to 10% per month at most. That's huge compared to 4 to 5% or 2 to 3%. It's still low compared to 20%, which might be your age-related norm. You can do that treatment for up to 6 total times, but 3 times is usually the line of the sand because odds start to drop after that. So cycle 4 and 5 and 6, the odds drop lower and lower. And honestly, they get where they're not that much different than just having intercourse. So why spend the money or emotionally go through the effort? Now, that's treatment 1. That I like to think about is still very similar to trying to conceive naturally. We're just capturing every aspect of it. We are making sure you're ovulating, watching with ultrasound. Usually we use a trigger shot. We are going to put the sperm closer to where it needs to be. You may be on progesterone in the luteal phase, and you'll be given a pregnancy test. So really taking care of all the options. The other treatment choice is IVF. There's a lot of different ways we can go through IVF, and we'll do an episode on that again in the future. I've got plenty of past, but let's simplify it to a genetically normal embryo. If you've got a genetically normal embryo that we're putting inside your body, you're going to have about a 65 to 70% chance of live birth, which is really nice and high. Now, that kicks the butt out of 20%, which is nature. IVF is the only thing that's higher than nature. It's going to kick the butt out of 8 to 10%, which is your IUI chance. And at some point, if you've done 6 IUIs, for example, you would have spent a ton of money that could have gone to IVF. So some people will skip the IUI portion and just go to IVF. It really depends on your goals and resources. When you are trying to get pregnant, when you have unexplained infertility, if you're going to do fertility treatment, what should you do? What can you control? The big overarching principle here and how I describe it to my patients is you're trying to decrease inflammation. That is your environment inside your body that is impacting your egg quality, but also where fertilization, early embryo growth, implantation have to occur. For male partners, this is impacting sperm quality for sure. All right, so here's a few of my principles and recommendations if you are trying to improve your inflammation. This is my hormone balancing, egg quality, sperm quality plan. So let's talk about food. We're going to encourage fruits, vegetables, whole grains, fiber, healthy fats, plant-based protein, vitamin D, vitamin B12, omega-3 fatty acids. You're going to avoid sugar, alcohol, processed foods, refined carbohydrates, fried food, processed meat, red meat, dairy, and gluten, at least at the beginning. I usually recommend a 30-day none of those, and then you can add back in dairy and gluten and see if your body has an inflammatory response to them. For everybody trying to get pregnant, I recommend a prenatal vitamin with 400 micrograms of folic acid, a vitamin D of 1,000 international units, and CoQ10 of 200 milligrams a day. Those are my basic for everybody. There might be some specifics we add on based on your medical state. So for unexplained infertility, because there's often a lot of inflammation involved, I usually add in more CoQ10. So I go up to 600 milligrams a day. I recommend vitamin C of 1,000 milligrams, vitamin E of 800 I use, melatonin at night, N-acetylcysteine at 1 gram a day, and omega-3 fatty acids at 200 milligrams a day. This is my supplement recommendation for decreasing inflammation, unexplained, etc. I want you to look at your world and eliminate toxins where you can. A lot of this comes from food, so whole foods, not processed foods. A lot of this is in your kitchen. I want you to use stainless steel, glass, porcelain. I want you to stop using plastic, stop using Teflon. I want you to really avoid anything hot with plastic. When you get takeout, I want you to put it into a different container so that it doesn't sit in that takeout container. I want you to use HEPA filters inside your home, avoid fragrance, avoid handling thermal paper, and then avoid smoking, vaping cannabis, limit your alcohol, things that we know are toxic, so limit your toxins. You need to use exercise to move your body. You need to decrease your stress. So my favorite stress reduction techniques: mindfulness, meditation, yoga, therapy, journaling, standing outside, feet in the grass, acupuncture, stretching, quality time. We're all wired a little different, so what may work for you may not work for me. And so find something that gives you that, and can really let you refocus and feel better. And you should move your body. I recommend a combination of strength training at least 3 times per week with low impact or moderate other activity. Definitely don't be a cardio bunny. You want to shift your thinking. And your focus is on being strong. And then sleep. Any big podcast I go on, the very first thing I say that you should do better is sleep. Your goal is 7 to 9 hours a night. But really, your environment matters. Charge your phone further away. Get blackout curtains. I love my sleep mask. Highly recommend. I have the Cozy Earth sleep mask in black. It is phenomenal. And consider a nighttime meditation. Don't eat before bed. Consider melatonin. Set the stage. And the last thing I'm going to say about this one, you and your partner are a team. They can't watch White Lotus at 10 p.m. if you want to go to bed. Do this together. Do all of this together. Top questions I get asked all the time. Does marijuana really matter? It does. It does for both eggs and sperm, especially sperm. We see an increase in miscarriage rates if the male partner uses cannabis, lower pregnancy rates, lower sperm counts. Do I need to quit drinking? I think we can all agree that drinking is inflammatory. Studies are going to differ, but you should not be having more than 1 drink in a setting, and there's no reason to be having binge drinking or multiple drinks or drinking every night. I usually say that should be a special occasion thing, just like added sugar or sweets. Don't need ice cream at night. That is a special occasion situation. And then I always get asked, do I really have to do all of this? And of course the answer is no. You're the one who should be in charge of your ship. You're driving it. You get to make the choices. Do we all know people who did everything wrong and got pregnant? We sure do. But if you are struggling, if you are having trouble, if you have infertility, if you have unexplained infertility, I'm now trying to put you in the position of being the one controlling the factors that you can, because so much is uncontrollable. So hopefully you can hear that long list of all the things I said and take from it what works for you and at least implement some change in your life. Any change, any drop of inflammation is going to be advantageous. So my recommendation before you do fertility treatment is to make sure all your testing is done. I see a lot of times where people will get advanced to treatment, especially by providers who have not sent them to a fertility doctor, just trying to help somebody out. But it does you a disservice if you don't have all the data. Can't make decisions on data you don't know. So get all your testing done so you try to know your diagnosis the best as possible. Make sure you give your doctor a really good history. We only know the information you tell us. Make sure that you understand what your odds of success are. If you have unexplained, for example, did you know your odds were this low? What are your odds without treatment? What are they with treatment? Make a game plan for if you're going to do treatment. What's it going to be like? How many cycles are you going to do? What are your odds of success? What will come next? When do you have a check-in? How many rounds do you do? And then you have a follow-up if it's not working. And then number 3, take control of the world around you. This is a great reason to get healthy. We are all looking to live healthier, better, more hormonally friendly lives. And I'll be honest, infertility was one of the worst things that happened to me, going through pregnancy losses, having ectopic. But it started me out on a journey that totally changed my life and how I live and ultimately made me so much healthier. If you have your own questions, please don't hesitate to call the As a Woman podcast at 657-229-3672, or you can leave your questions on Instagram on Monday at nataliecrawfordmd. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.